who don't know me, I'm Christina Marini. I'm a physiotherapist here at the Richardson. Today what we're going to go through is how to prevent hemiplegic shoulder pain after a stroke. So I'm just going to preface with talking about a little bit the stages of healing after a stroke. So normally if you've had a bad stroke, what ends up happening is that you lose motor function on one side of your body. As you go through the stages of healing, there are certain muscles that will develop more tone, particularly like your pec muscles, those muscles that draw your arm in onto the stomach. As you heal, you'll start to develop movements, but the movements are often in synergy. So, for example, if you were to ask somebody to make a fist, they'll make a fist, but their elbow and shoulder will also move at the same time. As they're healing, sometimes that tone can increase quite a lot in some people, and then it starts to subside. And then you start to develop more isolated movements where you can move your hands without moving the elbow and the shoulder. So I'm talking about those clients sort of at those early stages where they don't have any motor movement, or they're starting to have a little bit of motor function. So there's studies that have been done that clients with this hemiplegia, lack of muscle movement, a large proportion of those clients will develop shoulder pain. So there's about an 84% of these clients will develop shoulder pain. Also to note, clients in the geriatric population also have a higher risk of shoulder pain because through their lives they've had arthritis and injuries. The pain after stroke, it doesn't happen immediately after stroke. It usually happens 2 weeks to 2 to 3 months after the stroke. So what it is, it's an accumulation of little injuries to the shoulder that develop into pain. Here, though, we usually see our clients about 2 weeks after a stroke, sometimes even less. And so we're in a really good window of opportunity to try to prevent the pain. Once the pain starts, it's a little harder to get rid of. So if we can prevent it, that would be best for the clients. So in terms of pain, you know how when you're in a long car ride for a couple of hours and you're not moving, and then you start to get stiff and pain? That same thing happens with the shoulder. So if you're not moving, you can develop stiffness and pain. So what we try to do in therapy is we try to move the joints to keep the joint nice and healthy. Usually what we'll do is if a person doesn't have any pain at rest and they only have pain with movement, we're not going to medicate them, because when they come to see me in physio or in occupational therapy, I don't want their pain to be dulled. I want them to feel what I'm doing. In worse circumstances where a client has pain all the time, we will try to coordinate with you to try to have some pain medication before they come down to therapy so that we can do a little bit with them. Now, in terms of the impact of pain, pain has a big impact on what their ultimate outcome will be when they leave rehab. So if a person has shoulder pain, it can affect their function, so it can affect their bed mobility, their transfers, and ultimately their end result from rehab. Also to note that when a client has pain, there's an association between pain and depression. And often after stroke, we've heard of post-stroke depression. So here with all our stroke clients, we tend to screen for depression. So just to note that if there is pain, there's an increased incidence of depression, to be aware of that. Okay. So the impact of pain. So pain, we have a physical sensation, a person feels the pain, but it also has impacts on different realms of a person's life. So it can impact their mood. A person can be more irritable. It can impact them cognitively, where a person with a lot of pain might have less attention, and it can impact them socially. A person with a lot of pain can isolate themselves a little bit more. Now, what are the causes of pain? I'm going to go through a few of them. So the two in green are the ones that we'll spend most time with, but I wanted to talk about shoulder pain, shoulder subluxation. So I'm just going to back up a minute. If you think about the joints, so if we think about the hip joint, the bony socket is really deep. it's very stable. But when you think of the shoulder, the joint is really shallow. So what's really keeping the shoulder in place are the muscles, the ligaments, and the joint capsule. But once we've had a stroke, you don't have any muscle function, so it's really the ligaments and joint capsule that are keeping the shoulder in place. So if a person's standing and their arms in a gravity-dependent position, there's a lot of weight going through and a lot of pulling. So over time, if the arm isn't protected, they can develop a shoulder subluxation, where it's like a partial dislocation of the shoulder. In bad cases, when you're washing or dressing them, sometimes you will see a little dimple between the head of the acromion and the head of the humerus. In therapy, we kind of measure and see if there is that gap, so we'll palpate, and sometimes you can put 1 or 2 fingers. So we monitor it just to make sure it's not getting worse. Another cause of pain is spasticity. So remember at the beginning I told you there's certain muscles that will develop more tone through the healing process. So those are the muscles that bring the arm in onto the stomach, like the pec muscles. And what ends up happening is it creates a muscle imbalance in the shoulder, and then a person can develop tendinitis. A third type of cause of pain is adhesive capsulitis or frozen shoulder. This happens a little bit more commonly with clients that have diabetes. So essentially what it is, it's an inflammation of the joint capsule. Another cause of pain is immobility. So that's what we were talking about before. So if you're not moving your arm, it can become stiff and painful. The other thing that can cause pain is repeated trauma. So if a person's moving around during the day and the arm's pendant, it can cause a lot of injury at the shoulder. So what can we do to prevent shoulder pain? Firstly, education. If somebody knows that they're at risk for developing shoulder pain, they're going to be more careful. So that's very simple. The other thing to note, so everything we're going to talk about in terms of prevention also helps a condition called shoulder-hand syndrome or SUDEX. That's when if an arm is pulled or the vessels under the arm are damaged, it can cause swelling of the entire arm. The skin becomes glossy, really hot, and very painful to touch. But we're doing a good job. I haven't seen anybody with SUDEX in the last 15 years, so good job. But everything we're going to do will also prevent this condition as well. So the main takeaway message of the talk today is really that the arm should always be kept away from the body. So we talked about those muscles that draw the arm in. We want to keep the muscles lengthened and in a good position, so we always want to keep the arm away from the stomach. So this is a diagram of a gentleman sitting, and essentially the arm is at a bit of abduction, a bit of flexion, and at neutral rotation. So that, again, the arm is away from the stomach. Often we'll see our clients go down the hallway and their arms are often on their lap. So what we usually provide, the OTs will provide an arm support for the clients that need it. This is called an arm trough. So if it was my right side that was affected, this is how they'd be sitting. Another common thing that you'll see is a half table. The idea with these is that you want the arm to be nicely positioned. If it's too low, what ends up happening is that there's still a lot of tension at the shoulder. So we want it to be up a little bit to provide support. So the OTs will look at that when they first get their wheelchair to make sure that it's an appropriate height. Now, there's a couple of reasons why a person might be doing this. One main reason might be that the person develops left neglect. It's where their body isn't really processing that side of the body, so they're not feeling that side of the body. Another reason could be simply sensation. They're not feeling that arm as well. And another reason, some people tend to keep their arm on their lap in a more protected position. They feel more comfortable. But when we see our clients like this, ideally we'd want to help them bring their arm back up onto the trough to protect the shoulder. And also, if they're in this position a lot, what ends up happening is they can develop a lot of swelling in the hand. So in terms of positioning, we're going to move over to the bed. I'm going to show you 3 positions that we can use. Normally, a person with hemiplegia will have difficulty moving in bed. So these are the clients that often we have to move them every few hours. So I'm going to give you some options. So if we were to say it's my right side that's affected, in the geriatric population, the thing to note is that people are often more kyphotic. So if I go to lie down, you'll see that my elbow is behind my shoulder. But ideally, we want it to be at a straighter level because it creates less strain on the shoulder. So what I'm going to do is I'm going to put a pillow under the arm. The other rule of thumb that we talked about is that we always want the arm away from the stomach. So we don't want the person to be like that. We want them to be ideally like this. Sometimes a client that has a lot of tone is the muscles at rest are going to pull in and stay tight. So the hand is on the stomach. So an option that I would give you is to add another pillow. So what I would then do, still support, but I might fold a pillow in two. So this way the arm is not directly on the shoulder. It's not perfect, but it's better than having it directly on the stomach. So that's the first position. The second position is, what if you had somebody lying towards their affected side? Now the tricky thing about this is, if I go all the way onto my side, does anybody see a problem with this? Yeah, so your body weight is crushing the shoulder. It's the perfect way to injure the shoulder. So we never roll anybody directly onto the affected side. Instead, your option would be to have them roll part way, maybe 30, 40 degrees, and you would prop a pillow behind their back. So now the weight of my body is taken up by the pillow and not by my shoulder. So the other position would be to have a person lie on their good side. So when they're going though onto their good side, the thing you have to be careful of is that they don't leave their arm behind. That's another position where they can get injured. I'm just going to reverse sides. Imagine this is good side, this is affected side. So if I'm going over here, again, you have to make sure the arm comes with them. And the problem with this position, again, is that the hand is directly on the stomach. So I'm going to do the same thing I did before, where I would take a pillow or a blanket and create a greater gap between the stomach and the arm. Any questions about that? It's okay? So I'm going to run through these diagrams quickly because it's what I have just shown you. And they're dark. Okay, so the third thing we can do to try to prevent shoulder pain is the use of slings. So what I had spoken to you before about is that when a person is up, we don't want the arm to be in a pendant position. So even if it's just the 3 seconds it takes to go from the bed to the chair doing a transfer, the sling should be on and supporting the arm. So there's different types. This here on the diagram is one that you can pick up in pharmacies and often is used for a broken arm. This is another type that we have here. Lucy has retired, but she's our PAB and she has made us slings. So I'm going to show you briefly how to put it on. We try to teach all our clients how to do how to put it on. Those with cognitive deficits, though, it does become difficult. So step one, we're going to take one piece and we're going to put it at the level of the elbow. The second step, which most people forget, is the second piece has to go under the arm. We're then going to teach them to reach behind, pull it across the back, and then the second piece goes to the level of the hand and wrist. What I'd like to do is to add just one other step where you give a little tug. The tug just helps to approximate the shoulder and put it in a better position. So we'd be using the sling only for transfers, for standing if they're standing for a while, and for walking. Otherwise, the golden rule is keep the hand away from the stomach. So anytime they sit down or lie down, you're taking off the sling and you're keeping the arm away from the body. This is a diagram. We have some down in the department, but in case you ever want to put one up against near the bed, in case the families aren't remembering how to do it, typically some clients, what they'll do is they'll skip that second step. So they have it on, but then they'll go right around the neck, and that creates too much strain at the neck. Okay, the fourth thing we can do to prevent shoulder pain is through exercise. So when the arm isn't moving, we're going to give them some exercises to move that arm during the day. And so I'm going to head back over to the bed. So a common exercise I have them do is I'll have a person lie on their back. They're going to clasp their hands together, and I'm going to have them raise their arms up. I will ask them to do this exercise 5 times a day, and they're repeating it 10 times. Again, this will help maintain the synovial fluid, the health of the shoulder. So there's 2 things to remember. We often give this as a home exercise program. So there's 2 things to remember if you see people do it upstairs in their room. The first thing is that when they're doing it, it should not be painful. So let's say they're lifting their arm, but they start to develop pain here. We're never going to ask them to push through the pain. We're going to ask them to stay in a pain-free range. With the shoulder, if there's pain, it means something is getting pinched or injured. The second thing I have them do, or the second thing to pay attention to, is that when they're lifting, that they don't lift their hand past their nose. We don't want them to go too high. Now, the reason I say that is, if I were to go to reach for something in a cabinet, normally when I get to about here, my shoulder blade will externally rotate to allow greater clearance. If my shoulder blade didn't move, what would happen is the head of the acromion and the head of the humerus will pinch the tendons in between. So if I'm not moving my shoulder and I'm having them lift past their nose, I'm going to give them a tendinitis. I'm going to make it worse. So to remember always to stop at the level of the nose. Yeah, okay. So we use this exercise 2 ways. One is through, if a person has no movement, they can move through their range. The second way we use it is through strengthening. So if they're starting to get some muscle activity, we're going to ask them to move as much as they can their affected side and only help a little with their good side. So I'll give you an example. So I'm going to have them lift. They're using this arm as much as they can and come down. What I do see sometimes too is people will pull on their arm, and we want them to avoid that as well. So just so you're aware. Any questions about that? It's okay? Okay. So there's a saying, this comes to the point where if there's pain in the shoulder, you have to rethink what you're doing and you want to avoid pain. So no pain, no gain doesn't apply for the shoulder. Here daily also we try, in therapy sessions, we try to ask our clients if they have any shoulder pain because we want to see if they're developing it or if they have it, that it's not getting any worse and hopefully it's getting better. The 5th thing we can do to try to prevent shoulder pain is just in terms of how we're protecting the arm when a person's moving. So I would say as a general rule, you never want to hold anybody by the arm when you're helping them to stand, helping them to get up. And I would say that would be a good general rule to follow also in the geriatric setting as well. So I'm going to give you a diagram. So would I ask you to stand up for me? Could you be my model? So I'm going to have you stand facing them. So hypothetically, if let's say it's your left side that's affected and you're holding onto a cane and we're going for a walk, you can pretend you're wearing a sling. It feels good to kind of hold onto the arm. You kind of feel like I have a good support. However, if you were to lose your balance, my first reaction is to hold on. Can you actually move in the other direction for a second? So my first reaction is to grip. And as I'm gripping, the body is going in a different direction, and then you end up inadvertently pulling the arm. Thank you. So as an alternative, it would be better to hold somebody by the belt or by the waistline. Same thing when you're helping somebody up from a chair. It's better to hold at the waistline to help the person up instead of from the arm. This is just another diagram reminding you that when a person's rolling in bed, that they should never leave the arm behind. Now, I know you all know this, but I'm going to say it anyway. So when we're helping a person get dressed and they have a stroke, we always want them to dress with, put the sleeve of the affected arm first, because you have full range with this arm, right? You can do whatever you want, and the opposite when you're taking the clothes off. So that's essentially it. I wanted to keep it practical and simple. I hope that was helpful. Does anybody have any questions? No? Okay. Thank you very much.